Well, while we're waiting for Sanjay and Sarah to join us, I'll just kick off with just a little bit of housekeeping if possible. So if everybody who has a camera is able to keep their cameras on, that's really quite good so we can see who's part of the conversation. If you're not speaking, can you just put your microphone on mute so that takes out any background noise? And I was just going to ask if anybody wants to come in once we start talking about a topic. If you're able to put your hand up, that will show me who has a comment or any point that they want to make. Sarah Frisbee's here to record the meeting for us because obviously this is our first round the table session that we're going to be sharing with the public about the proposed 6-week engagement of the merger of the 3 CCGs. And Jane Meggett will be joining just to listen in as the Director for Patient Engagement after she finishes her current meeting that she's on. So I just thought it would be quite nice if we just said a quick hello and who we are, just so that everybody knows who we're talking. So hi, Alison Borrett, I'm chairing and I chair for Patient and Public Engagement and I vice chair to Nicola Smith for the CCG. If I can ask then Sarah to come in. Sarah, do you want to come in? You're on mute at the moment.
That's because I put myself on mute when you told me to, Alison. I was a good girl. Apologies. So my name's Sarah Frisbee. I'm the Senior Communications and Engagement Manager for Bedfordshire and Luton and Milton Keynes CCG.
Thanks, Sarah. Over to Roshan.
Roshan Jalat, local GP from Bedford, and I'm also a GP governing body member for the CCG.
Thank you, Roshan. Laurie?
I'm Laurie Hearn. I'm Manager and Company Secretary for Healthwatch Bedford Borough.
Thank you, Laurie. Chris?
I'm Chris Longstaff. I'm a GP in Central Beds in Leighton Buzzard, and I'm also a GP governing body member for the CCG.
Thank you, Chris. Maxine?
Hi, I'm Maxine Tapatani. I'm the Chief Executive of Healthwatch Milton Keynes.
Thank you, Maxine. Phil?
Phil Turner, Chair of Healthwatch Luton.
Thank you, Phil. Kirti?
Hi, I'm Kirti Singh. I'm GP in Luton and also a governing body member.
Thank you. Nicola?
Hello, I'm Nicola Smith. I'm a GP in Milton Keynes and Chair of the BLMK CCG.
And I just see that Sarah's joined us. Sarah, we're just doing introductions. Would you be able to introduce yourself for us, please?
Hi, I'm Sarah Whiteman, GP in Milton Keynes and Executive Medical Director for BLMK.
Excellent. Thank you, everybody. We've had late apologies from Diana Blackman, who is Healthwatch Central Bedfordshire. Unfortunately, she's not very well. And we've also had apologies from a couple of GPs who are actually on annual leave, so we're unable to make it. So for me, it's just to chair the sessions and the questions. So what I wanted to do is just hand it over now to, if we maybe start with Healthwatch from any questions that you've got, and then if we can just facilitate the discussion, that would be great. So who would like to kick us off today?
I've got a couple of questions, really. I saw a PowerPoint presentation that Sarah did for the public engagement plan. And on the, I think it's the third slide, it talks about a key role with 2 emergent integrated care partnerships. What are they going to be? Is that another layer?
Who would like to take that?
Do you want me to, Alison?
Thank you, Nicola. That would be good.
I was just while you said that, I was just contemplating, is that a layer or is it something else? I think it's definitely, I think we don't want too many layers, do we? Definitely. So I think that's kind of the first principle to mention. The two sides of the 2 health economies that have traditionally kind of worked together is the Bedfordshire side, which probably includes Luton to some extent, and also the Milton Keynes sort of health economy, which is kind of quite well, we've got the quite well contained with the hospital, local authority, community services and all those kind of things. And then they've got the Bedford, of course, the Bedfordshire Care Partnership, where you've got the Luton and Dunstable Hospital now merged with the Bedford Hospital. So there's 2 kind of, if you like, 2 separate health economies. So the Integrated Care Partnership would be, slightly different on different sides of the whole BLMK patch as such, but I don't see it so much as an extra layer, more of a kind of a dividing things up for effective working, if you see what I mean. So, and actually I think naturally things have fallen that way. It's not been us that people suits in a darkened room saying we need to divide it into two and this is the dividing line. It's very much the sort of natural way things have evolved. So I think that's what I would say about it. I mean, others may wish to kind of comment as well.
Maxine, did you want to come in?
I had a different question, but I think against the integrated care partnerships, my only comment really would be that during the engagement document is a bit difficult to understand if you aren't aware of what an ICP is, to kind of understand it in the context of the consultation. So there could be some additional information on the website about what that might mean locally for people. My question was just to GP members of the CCG board, just keen to know what concerns GPs share in commissioning across a large region under a single commissioner in the future, and what that might feel for their patients.
Who would like to take that? Chris, I've got your hand up.
It's a good question, and it's made me think. My anxiety as a GP tends to be on what is directly going to influence my patients. And there are some things that we have locally that are some services which I think work really very well locally. And my anxiety would be whether they get lost commissioning at scale. Those little sort of examples of excellence that I really, really rely on and my patients benefit from. And so I suppose one of the things that I will be looking to do is to be a voice that makes sure that those little pockets of excellence are spread more widely rather than sort of seen as creases to be ironed out. But there's a flip side there as well. Does that make sense? That's my anxiety, is those excellent things get lost, but also I think there's probably an opportunity.
Thank you.
People might have others.
Thank you, Chris. Kitty, you had your hand up.
Sorry, I don't know what's happening. So yes, I actually agree completely with Chris. Little things that we do very local, place-based is our anxiety, but having a lot of discussions like Chris with yourself, with Roshan over the months, I have realized actually it is an opportunity that the things, I will give example, Maxine. So I focus very much on learning disability and serious mental health checks. Last year, I've been focusing a lot in Luton, and it has improved Luton data. So in fact, Luton is best among the patch with the health checks. So what I don't want is our Luton place to be lost. But what I could do at other region is actually bring my skills and what I have already done in terms of how did we get to where we got to other areas without starting from beginning. So we had various meetings between myself and Roshan and Krishna, all three leads from different areas for mental health, to see what we can share and how can we just focus on very few areas and then strengthen those areas and then bring the skills or the groundwork that we have done to all three areas to actually maximize our input. So Roshan doesn't have to repeat what I have already done. And similarly, I don't need to do what Roshan is doing for dementia patients, because I can just ask Roshan to hand over the groundwork that he's already done for me to pick up from there. So I think, yes, I was actually nervous, to be very honest, but with all the conversations and the meetings, especially during COVID, we are actually having a lot of more meetings that never happened before. I'm getting that assurance that actually we can work it in a very positive way because communication is better. And that really is the key.
Thank you, Kirsty. Roshan, you had your hand up.
Yeah, Yes, Chair. So I would answer the same way as well as Curti was saying. So it's the collaborative working pattern that we have changed the system, okay? Because we were kind of isolated working earlier as a single CCG structure. So we have changed that pattern into a collaborative working. So that has helped quite a lot actually. I think as a GP, I'm getting the feeling actually I had the same kind of anxieties as Chris said as well initially, but with coming of the shadow CCG structure now, so I think I'm feeling kind of assured now with some issues like that actually, because how the collaborative working, how we can work as a group now rather than isolated working. So I think it has given a strength to us rather than a negativity to us. So that's what I feel actually.
Thank you, Roshan. Nicola, would you like to come in, and then we'll go to Sanjay.
Oh, thanks. Yeah, I think merger in itself doesn't obviously bring about all these improvements. It's just everybody's commitment to working together that's brought about. And I agree with what Roshan and Curti have just said, in that I must admit, you've told your CCG has to merge with others, and you think, oh dear, what it's going to be like, what are the other people like? But I think we've been working together long enough now to really sort of embed the sort of improvements that we can make, and I think the localism part of it we need to retain, but we need to just keep working at it. It's just not going to happen by itself, and I think we're all committed to that side of things. The example that I was going to bring up was working around the care homes during the pandemic, and we've worked as a whole BLMK group on that, and Chris has been part of that as well. And we've been Luton has kind of have been rather a lot ahead of us in that particular bit of work, and we've been sort of Bedfordshire and Milton Keynes CCGs have been sort of scurrying along behind, trying to catch up and trying to make the improvements that were already in place in Luton. So it's been a big eye-opener, and it's really nice, and you can see by all my other GP colleagues on the call how fantastic it's been to have new people to work with, and who are really excellent and really committed to providing good care for patients. And I think that really shines through in that the new kind of, we're working as if we are merged really, but the lack of a merger means that we have to do things 3 times over. So I just really wanted to support what other people were saying.
Thank you, Nicola. Sanjay, over to you.
Yeah, well, I look at it in terms of a glass half full, a glass half empty scenario, to be quite honest. We can say we want to preserve the localism. I think that will be preserved by means of the PCNs, and I hope, with my glass half full attitude, that local excellence is reproduced throughout the SDP, throughout the footprint, and that will be beneficial for all the patients. It will be beneficial for the localities, and with the collaboration Roshan has been talking about, and with the speed at which we've had this collaboration due to COVID, I hope this goes at a pace as well.
Thank you, Sanjay. Chris, you wanted to come back in.
Just an afterthought, really. One of the things, Maxine, that I suppose does make me anxious, and I think we need to be really careful of, is to protect relationships. So I have a relationship as a GP with local service providers and local specialists, and actually the fact that I know them and there is a link means that I'm able to offer a much higher level of care. And sometimes if you're commissioning services at scale, there's maybe a risk of a loss of that local link. So if I give you the example of, I was seeing a complex mental health patient recently, and I just sent an email to the local consultant who I know very well. I knew that he would give me a sensible answer. I knew that he would respond to the email the same day. And he did, and sent back some suggestions. And I wouldn't feel confident to ask that of someone who I didn't know. And that link is really important. having said that, he works for ELFT, which is commissioned at scale, and that's set up in a way where actually there is still localism that works and remains, and he's worked there for a long time, and I hope will continue to do so. If I think of the musculoskeletal service, that's an example where I would say that localism is preserved in some ways and not in others. So there are some examples where it's worked well and less well. So sometimes when I refer into the system, it feels sometimes as if a referral goes into the system and I'm chasing it, not quite sure where it's gone to. But then I think partly to respond to that, my practice now houses 1 day a week someone called Chris, who again I know and joins us for coffee in the coffee room wearing a face mask. And actually it's really useful for me to know a representative from that service. So there are ways of doing it, and it can be done more or less effectively. And I think that's something also that we need to keep a really close eye on.
Thank you, Chris, for that. Sanjay, your hand's back up. Oh, it's dropped down. That's okay. Maxine, did you want to come back on that, or can I go to Phil for his question?
Sorry, I raised my hand instead of unmuting myself. No, thank you. Thank you for your responses there. I think one of the things that stuck out for me when I was going through the engagement document and filling in the survey myself were the options around ensuring that primary care funded was ring fenced for 2 years, and what does that really mean to me as a patient? You know, how do I know why that is important or not at this stage? But I think those examples that Chris and Kirsty have mentioned about those kind of pockets of excellence in GP practices are really important, so thank you.
Sanjay, you've popped your hand up. Did you want to answer on that before I go over to Phil?
I mean, I look at it in terms of in Luton and Dunstable, we have Consultant Connect, and we're building relationships with consultants. More and more so. We started off with about 4 options, now there are now 12 on Consultant Connect. So the analog phone is not running out of space. But what do you consider as local with the advent of this larger footprint? Eventually, our relationships are going to be with people on a wider scale, and we're going to be building on those relationships with time. So you have to think of it in 2 ways. Yeah, if you build on those relationships in the ICP, then the patients can benefit also, in my way of thinking.
Thanks, Sanjay. Thank you. I think you make a really good point, and you've all talked about relationships, and that's whether that's with local, that's whether as the 3 CCGs are coming together, those relationships are really important, I believe. Phil, your question, if I can move on to you.
Yeah, 2 things really. One, Laurie asked about integrated care partnerships, which, Laurie, was a question I asked some weeks ago on another one that I was involved in. And I'm not sure I'd call it another layer, but prior to the whole COVID issue, I was involved in a number of activities in Luton, models of care being one where we were looking at frailty with elderly frail people and admissions to hospital and so on and so forth. That has disappeared now for a whole pile of reasons, not least of which with the COVID lockdown. But the focus on that has kind of gone out the window, or at least I'm not hearing anything. And actually, the person who was program managing that from Cambridge Community Services popped up on another conversation I was on and is now employed by Luton Borough Council. So that does seem to have gone out the window without any communication really going on at all, which is concerning. However, I was also then asked to partake in an introduction by somebody who is working out of Luton Dunstable Hospital, who is looking at elderly, frail and hospital admissions across the BLMK patch. So it has gone up a level, but I have to say at a local level, so that's kind of now 6 months where nothing's happened, and we were making really good progress. And she did say, the person who was heading up that did say that they didn't want to lose all the good work done and the focus done. But I have to say, I'm finding myself completely out of the loop now, which is a bit worrying or a bit concerning. So, and you know, when it comes to integrated care partnerships, I know that Nikki Pillane is responsible for the primary care across the patch, and that's somebody I know, and I kind of understand all that. But I do feel at a distance from BLMK, whereas I was reasonably involved when it was at a local level. So that does give me a level of concern, although I do totally understand economies of scale and learning and best practice, etc., etc., etc. Second thing I'd like to mention is on a meeting last week on public engagement, the questionnaire talks about people's belief in it, etc., and it's about this thing about the decision has already been made. So asking people whether they think it's right or not is kind of a bit back to front. We talk about people being done to rather than being done with, and we want to involve people and all the rest of it, but this is definitely outside of our control, and I know it's government directive, but it's being done to. So the wording about how that is communicated to the public, I think, is very, very key. You know, and I don't think there's anything wrong in BLMK saying the decision has been made centrally by central government, and then the consultation is about how that is implemented, not whether it's implemented. Those are my 2 points, really.
Thank you for that, Phil. Does anybody want to come back to Phil's 2 points?
Well, that'll end the conversation early then.
Chris has got his hand up, and then Nicola's got her hand up. Chris first, then Nicola.
So I suppose a general answer to the first point is, one, I'm sorry that you feel less involved in the BLMK work being done and the new organisation. And this is maybe a question back to you. I wonder whether there is something about the formation of any new organisation which means that it takes time for people to feel truly embedded in it and to have developed those links in it. And I wonder whether is that just me trying to find an excuse, or do you think there's a possibility that we're in an early stage and that could develop, which leads me on to my second point, which is, how could we develop those links more closely from your perspective?
Well, on the first point, the models of care activity within Luton, that was a weekly meeting, every week a meeting which involved social care, which is the other whole issue about health and social care, which is another discussion and a topic which needs to be had. But that was a meeting which happened every week involving GPs, the council with social care, Health Watch, Cambridge Community Services, and every week and making progress with an action plan and things moving forward. Nothing has happened on any of that. And in fact, the people who were program managing it have now left and gone somewhere else. So, you know, I would love to know where that plan is, what's taken it over. And I understand that with the lockdown and COVID, it's all a bit different now, and I don't dispute that. But it would have been nice to have a kind of a closeout, a handover, this is what's taking over from it. This is the plan moving forward. This is what we've learned from what happened in Luton that can be implemented in Milton Keynes, Bedford Borough, Central Bedfordshire, but nothing. Complete, total and utter silence for now what has been, 4 or 5 years. And that kind of feels like people have just dropped the ball. And it was making good progress, which was benefiting a lot of people.
Thank you, Phil. Curtie, your hand is up. Can I just go to Curtie and then go to Nicola?
Hi, I just wanted to give you an example of Luton, Phil, because I am involved in Luton. So when we stopped those weekly and monthly MDT, which was supported by CCS during COVID, there was something called as discharge huddle that was very quickly pulled up. In that discharge huddle, every patient that was being admitted in the hospital and was being discharged in the community, there was a group formed by CCS, Nina, myself, and few other GPs, Chirag, Surina. So every day, 3 times in a day, we had this meeting, 8 o'clock in the morning, 12 o'clock in the afternoon, and 4 o'clock in the evening, to discuss any discharges, any frail patients that are going back in the community with any challenges and anything that is not being picked up. So we picked that bit, and it went on for approximately 3 months, 3 times a day. Then we reduced it to twice a day, and then once a day. And then we stopped it just very recently because there was less and less concerns coming from that consultation. So that was very quickly formed, and it was running very smoothly to support. And the reason was that during COVID, whether to get access to patient's own GP, it would be challenging. Some will be shielding. So we didn't want patients to go back in community without any support. So that
No, I appreciate that, and the MDTs were happening whilst the models of care meeting were going on, and they continued to happen for all the right reasons. It's everything else, you know, the progress, the action plan, you know, who's taken over that action plan about moving forward on what activity was happening to make those improvements. The MDTs were happening when we were doing the models of care programs.
So the MDTs we as a GP were supporting, that was monthly MDT. We had a phone call with CCS that was 2 weeks ago. Last week I was on holiday, so approximately 2 weeks ago, and we asked, and it was a very meaningful meeting about reinstating some of those MDTs, and so they came back that they do not have full capacity for all GP surgeries to start MDTs, but they said that all the GP surgeries who are struggling, or they have got patients, or they have made progress already, they are going to start those MDT ASAP, so which will be from this month, I would have hoped. I can feed you back once they have started to give you more reliable information, but this discussion was from approximately 2 weeks ago that we have asked, and in fact everyone, exactly as you have raised, that now we should start them back because we've already made such a huge progress. It will be a shame to lose all that work. So we are discussing that, and hopefully from the end of this month, they will all start. Not for all practices, it will be phased up. And the reason is because CCS is still pretty much occupied with a lot of other things they're supporting, but they have said that they are now in the capacity to kickstart some of these MDTs.
Thank you for that, but I guess you make my point. Why am I hearing it from you 5 months down the line?
I think, Phil, as
general communication to everybody would be more helpful.
Okay. And I think there's some comments in the chat box. Chris put, I think Phil makes a valuable point that we owe it to people to be clear and communicate clearly with conversations or work forward if there are changes in how we are working. For me, this is a useful learning for the future. And Roshan has put, yes, we're starting back again from September. So I think that was a really good point and question that you asked. Nicola, did you want to just come back in on that and then we'll move on?
Yeah, it was just reassuring to hear that, I mean, the work is not lost. And I think I'm just going to say that frailty is no less of a priority than it was before COVID. I think the emphasis just changed ever so slightly with the big focus on care homes, and the energy had to go into more specific things. But we're not, clearly from what people are saying, we've not lost the original sort of work and the original learning. I think the other bit that you mentioned, Phil, was about the honesty about the reasons for merging, and it is absolutely an NHS policy for us to form bigger organisations, and I, you know, like everybody else, we all believe in a national health service. So there are some things that we need to sort of follow the sort of national directive in a sense. But you're absolutely right. We're following that directive. We're not going to vote for it because that's daft, because you know what, the vote won't matter. But we do want to form it in very much the way that we want to see things being done. And you can hear around the meeting, you know, people are enthusiastic about that. And I think the one big thing just to to say is that we're not voting for a merger, but we got our GP member practices to vote to support our new constitution, and overwhelmingly they have supported it right across BLMK. And that's not just because we've written a constitution and they like it, it's because we work really closely with the local medical committees and modified it according to the needs and the desires of our member practices to make sure it is a very much more robust constitution going forward. So the building blocks are getting there, and I think honesty is really important. And I think what you're hearing around the room actually is a lot of honesty.
I think you're right, and that's around the room. What I think my concern is about how it's communicated to the public.
Thank you, Phil. Yeah, and I think part of what we're doing today is about how do we work with yourselves as Healthwatch and give you that airtime with the GPs to represent the public feedback that you pick up through Healthwatch and have that conversation open around the table, and then obviously record it and share that back with the public. During COVID, obviously it's really difficult. We can't do the face-to-face, so it's thinking about how do we keep this communication and relationship airway open so that anything that does come to surface, we're actually dealing with it, and it's getting voice time as well between yourselves and through the CCGs. Curtie, you've still got your hand up. Did you want to come back in? Okay, fine. So thank you, Phil, for that. A good debate. More questions? Anything from Laurie or Maxine or Phil again?
I've got another question, if I may.
Yes, certainly, Laurie.
Some weeks ago, we had an email from people who were getting the BLMK website ready, and they were asking for suggestions. And one of the things I put forward was the use of a system called BrowserLoud, which translates the spoken language on the website into 35 different languages and translates into 70 different languages. I've not heard a dicky bird back from anybody. I just wonder whether these things are going down a black hole again.
Would anybody like to come back in on that? I can just give you an update from the patient and public engagement meeting that I chaired, is that it is in its infancy, and Michelle Summers and the communication team are looking at all the feedback. I believe obviously it takes time to make changes, but I'm sure if you've not heard anything back, Laurie, I will take that to Michelle and ask her to come back with you direct, because obviously we want to make sure that the website is easy to navigate through, but also that if there are different languages, people are able to understand and see what's on that website. I don't know if anybody else wants to come in with that.
Hello, Alison. Sorry,
Hi,
I've only just joined. Thank you, Laurie. I think, as Alison's just said, it's baby steps with our website. So let me take that back and find out the detail, because the engaging with the different languages is absolutely critical. We've learned from COVID how important it is, and if we can expedite it, we will. So leave that with me, and I'll make sure that I circulate that to everyone. Thank you.
Thank you, Jane. And also in the chat box, Sarah Whiteman's come in to say that she agrees we really want to hear suggestions regarding potential solutions and approaches from colleagues like Healthwatch. So we need to keep that two-way communication really wide open. Thank you. Chris, you've got your hand up.
I just wondered whether there was a more general point that follows on from Laurie's point there, which is something about the fact that we really value suggestions like that. And I think it's really important that you don't get the sense that these things do go down a black hole. And it's useful that we demonstrate to you that we find it useful. It may well be that the person who received the suggestion found that very valuable. But actually, unless we're closing that loop and getting back to you, even whether it's a yes or a no, I think it risks disincentivizing you from making more in future. So I'm pleased you've raised it, and I think we need to be, even if we're not able to take suggestions forwards, I think it's really important that we close the loop when there are suggestions made.
Thank you.
Thank you, Chris. Thank you, Laurie, for that. Good question. Okay, Maxine, Phil, anything else, or over to the GP colleagues, anything that you want to talk about?
I've got one other, if I'm. Oh, sorry.
Okay, Maxine first, then we'll go to Laurie. So Maxine, on to yourself.
Okay, thank you. It kind of goes on from what we've been discussing about relationships, really. I think I agree with a lot of principles around the merger to a single CCG, but I do worry about the large systems underneath there, particularly the issues that for Health Watch in a big under a single commissioner might have in terms of maintaining relationships, how that single commissioner maintains relationships with a large voluntary sector base, particularly where they may be at more threat of funding opportunities as a result of larger at-scale commissioning as well. And just really what people's thoughts are around how Health Watch can ensure that that we maximise our strategic relationships with you as a single commissioner. I mean, COVID has got in the way, but as Health Watch Milton Keynes, I mean, prior to COVID and the move to a shadow commissioning body, Health Watch Milton Keynes sat on the CCG governing body as a full member, and we had one-to-one meetings monthly with its chief operating officer. So those relationships have already altered quite considerably as part of being on the shadow, as part of the move to the shadow board, and I accept some COVID interruptions as well. But it'd be quite interesting how, you know, we could work with it. We're quite small organisations, and the voluntary sector that we often work alongside are quite small as well. So how can we work more strategically to get our voice heard, and obviously the voice of our citizens and patients?
Thank you, Maxine. Sarah, you've got your hand up. Would you like to come in, please?
Yes, I wanted to say, Maxine, that I think as time goes on, we've spent a lot of time doing our organisational restructure, and that has diverted a lot of attention and energy from people. But we have put so much emphasis on place-based teams that I think those relationships will be picked up again quite soon, once people know that they've got their job and what their roles are, and they're still going to be in Milton Keynes, Bedford Borough, Central Bedfordshire and Luton. I think that will come again, and then we'll definitely have more patient representation in our clinical groups and at the integrated care system level. So I think that's a real intent for the CCG and the system as a whole, actually.
Thank you, Sarah. Phil, you've got your hand up.
Yeah, I think following on from what Maxine says, we Health Watch find ourselves in a little bit of a strange situation, because Health Watch has a responsibility, and a statutory responsibility, for health and social care. Now, health is forming itself as one ICS under BLMK. Social care still remains with the individual councils and local authorities, and you know, that one BLMK CCG working with a number of different local authorities who are responsible for social care, and those number of individual local authorities that have different political persuasions as well doesn't help. I see that as somewhat confusing, and well, confusing. It's going to take a lot of work and a lot of skill and diplomacy, I think, to get the social care and the healthcare working together, and Health Watch, which has a responsibility on both sides of that.
Sarah, your hand's back up. If I'll come to you first and then go to Chris. Thank you.
Yes, it's really to say that I completely agree with you, Phil, and that I think any of us who've been involved in the integrated care system, the ICS, since its inception, would agree that an area of development for us as a CCG has been our working relationships with the councils. And the ICS, of course, is a partnership that involves councils and healthcare, including providers such as hospitals and community trusts and the CCG. So yes, it is a challenge, and it's all about partnership, and again involving Health Watch and being diplomatic and political with a small p, absolutely essential.
Yeah, it's working in collaboration and with, and I think that's the key to the whole thing. I just hope that all the other organisations have the same view.
Yes, well, of course they don't, and it varies at different times, but that's part of the course, isn't it?
It's the challenge, I think, is what we
Yeah.
say.
Phil, Chris, do you want to come in, please?
It was just a question back, really, on that point, which is I can see the value of the different health watches engaging with us, with representatives from all of the different areas in the room, and I see value in that. But then I also see value in place-based conversations happening too. And I wondered what you thought the right balance might be for the future, and where should the majority of those discussions be happening? It's just a question. How much do you want to engage with this collectively as a group at BLMK level, and how much would you like to be engaging at place level?
I think you can feel you have more influence and more impact at a place level. Certainly the Transformation Board in Luton, we had a very good relationship there, and with primary care throughout. I think I go back to this philosophy that we had previously, which is we need to talk about dealing with the person and not the symptoms or the illness or the difficulty in housing or whatever. It's about the person. And those issues of mental health, of social care, of healthcare are all very, very much interrelated and integral to the human being and the human being's welfare. And I guess we need to make sure that we keep that in absolute focus. And that can be done, there are big things that can be done across the patch which benefit from the economies of scale, but equally we mustn't lose sight of the smaller things that we can do for the individuals and the local place-based issues that arise across the patch.
Sarah, you've got your hand up, and then Roshan. So we go to Sarah first and then to Roshan, please.
Yes, just to say, Phil, I completely agree. And the way that we're working now with PCNs and strategically is actually looking at population health. So having that place-based focus, so we understand the needs of the population in Luton, so that the patient experience is then the best it can be. So that means that we're looking at placing resources in the right place in the right way. But ultimately, it is, as you say, to improve that individual patient experience. And I think once we can join all that up, it will feel a lot better for everyone and at every level of the system.
Yeah, I think back to just the person's at the centre.
Yeah.
Roshan, would you like to come in?
Yeah, I echo what Sarah was just saying, because I think the new structure within the CCG, I think we have given quite a prominence as the place-based structure. Because if you take that example of mental health wise, we have given actually the place-based mental health leads to all the areas. Strategic leads are separate and the place-based structure is separate as well. So the place-based structure has a very high prominence within the new structure. Adding to that, we can say actually with the new PCN directors, so that's again a place-based kind of a presence. So that structure, I think, giving a more authority compared to the before. Actually, as a single CCG structure, we never had that kind of a presence. That's a high kind of a clinical presence within a place. So I think it has changed quite a lot within the new structure.
Maxine, you've got your hand up. Did you want to come back? You're on mute at the moment, Maxine.
I keep lowering my hand rather than pressing on mute. Yeah, it was just a comment really on the conversation in terms of, I think much like the kind of integrated care system and the single CCG and the importance of working in partnership with local authorities, etc., and that is going to be more and more at scale. As a local health watch, first and foremost, my duty is to the patients, the residents and carers and service users of Milton Keynes. But, at a scale level, we will all take a responsibility for those residents of other Health Watch patches. There will be times where we will have to weigh up information that our patients are saying in our local area or place against those of other areas as well. So I think we're also needing to think a lot more strategically as partners amongst Health Watch moving forward.
Thanks, Maxine. And Maxine, also thank you for your comments. So in response to Sarah talking about the restructure across the CCGs, Maxine's popped in the comment box that she absolutely does note that this is a challenging time for those working in the CCG going through their internal restructures. So thank you, Maxine. Laurie, did you still have another question you wanted to ask?
I did, please. In the last day or so, the Parliamentary and Health Service Ombudsman has published a document called Making Complaints Count. That is one of Health Watch's major areas of work in terms of signposting and stuff like that. And complaints handling in the NHS is very complex, and there is a draft framework that's been published now by the PHSO. And I do hope that the CCG will take this on board, that when people have got a problem, there's a very short way of getting their problems sorted out. Even if it's an 0800 helpline in each patch or something like that. Complaints take too long to get sorted. So anyway, the Making Complaints Count is the longest document, well worth a skim read. Thank you.
Does anybody want to come back on Laurie's comment?
Sorry, Sarah here. I think probably it's one for us to take away and to talk to our complaints and FOI team about. Thanks, Alison.
Thank you. Kirsty, did you want to come in?
I wanted to say about individual patients' complaint procedure or in the surgeries. There's a very straightforward policy that is not complicated. So if patients, they wish to complain about something not working for them or they're not happy with the services, within each practice there is their own complaint policy. As a CQC requirement, we have to have that policy, and as a deadline timeline very short that we reply to them. So very, and I think it's all over Luton, Bedford and Milton Keynes, all over England they should have, and so that is at practice level. But some patients, they choose not to go to practice. Straight away they go to NHS England, then that becomes complicated because that policy is not straightforward, neither for patients, not for practices, and because it's got a structure. So then NHS England's write to us that your patient has complained, then we write back to NHS England, and then NHS England writes back to patient. So that has got a big, it's not straightforward, but patients do have a choice to make complaints directly at a practice level, and only if that is not resolved, then they can escalate. But if they choose to take it directly to NHS England level, there is nothing much we can do from practice because there is a policy, there's a pathway that we follow. Unless it comes to us, we cannot reply and we have to reply it back to NHS England.
Thank you, Kirsty. Nicola, you had your hand up, so I'll go to you and then to Sarah.
Okay, just a quick one, really. I think that my experience of the nature of some of the complaints that the CCG receives is that they can be quite complex and quite complicated, and often sometimes involved at least one provider or various different people. They're often patients who have ended up, like Kirsty says, perhaps they've gone to the GP or they've gone to the hospital and they haven't really kind of got a resolution to their complaint, so they can be quite difficult to sort out. So that sometimes means it's a little bit time consuming, but I think the important thing is to keep the complainant informed all the way along, isn't it, with regular contact, so that if there is going to be a delay, that people are kept informed about the progress of it. So I think it is an important thing, and I think it's the CCG is just one place people complain to, and so you need to bring those complaints in together with complaints from the whole system. So you need some way of sort of integrating it across the whole of BLMK, don't you, rather than just looking at it in sort of splendid isolation. I think it is quite a complex matter, but I'm glad you brought it up, that's all.
Sarah, did you want to come back in?
Yes. I just wanted to say that making complaints count is all about really recognising the learning from complaints. And one of the most important things when somebody does complain is to identify what they're hoping to achieve from that complaint. And that sort of step of understanding can help in the whole achieving the outcome. So not necessarily around timescales, it may be just around getting an apology or changing a pathway or something like that. So obviously that's going to take time, and I think if we set that out at the beginning, it's sort of like doing expert triage, so you can map the pathway of the likely pathway of the complaint. There's a lot of work we can do on that, there's no doubt about it, and we have got a new team in the CCG who will now be working to Geraint Davis, so I'm hopeful that we'll be dealing with them much better.
Thank you, Sarah. Excellent. So I think that's Laurie's question answered. Is there any more questions that we've got, or any comments that anybody would like to make on today's call? I'll take the no hand sign as no. I think some really good questions. I think definitely, Maxine, what you talked about around the explaining ICP, that obviously is something that the comms team will take away and have a look at. We talked a lot about relationships, which I think is really, really important. And also we talked about some sort of practical advice around complaints and website and reaching out to the patients and the public of the newly shadow working BLMK. So if there is no other questions, then I would like to just thank everybody today for their time. It's been really, really useful. As I said, this is being recorded and this will be shared with our patient and population across the 3 CCGs. And obviously, with face-to-face conversations being very difficult, this may be something that we continue to choose if we believe we get the feedback. And obviously, asking Health Watch, you are the eyes and ears as well of our public and the patients. So it's really key that we work with you and listen to that feedback. But thank you everybody for your time today, and all stay safe. Thank you very much.
Thank you.
Thank you. Thank you.